Hi, I'm John Strickler from Duke University Medical Center, where I'm a GI medical oncologist. It's my pleasure to present today Telisotuzumab adizutecan, which we call Temab-A monotherapy versus trifluridine tipiracil plus bevacizumab in patients with refractory metastatic colorectal cancer with increased c-Met expression. This is an open-label randomized phase 3 trial. The objectives are twofold. In Stage 1, to determine the recommended phase 3 dose of Temab-A monotherapy and further evaluate its safety, efficacy, and pharmacokinetic profile. In Stage 2, we'll be looking at whether Temab-A monotherapy is superior to our current standard of care, which is TAS-102 plus bevacizumab, in terms of both response rate and overall survival, and to also review efficacy, safety, and impact on patient-reported outcomes. I think it's important first to start with a background on why c-Met. c-Met is a protein that's been reported to be overexpressed in many solid tumors and colorectal cancer. Temab-A, Telisotuzumab adizutecan, is a c-Met-directed antibody-drug conjugate consisting of this antibody, Telisotuzumab, conjugated to a topoisomerase I inhibitor payload. And we have previously shown very promising early results from our initial first-in-human study that was presented last year at ASCO, showing a response rate of between 15 and 20% in this patient population. But in patients who have higher levels of c-Met expression, where you would have more uptake of the drug, you see response rates of more than 30%. And so it looks like selecting for c-Met expression does generate a higher response rate. So now we have a phase 3 study in development, ongoing, comparing the investigational therapy, Temab-A monotherapy, against our current standard of care, which is TAS-102 plus bevacizumab in patients with chemotherapy refractory metastatic colorectal cancer. But the key eligibility criteria here is we're selecting for those patients with high levels of c-Met expression, which we define as more than 10% of the tumor cells staining with strong intensity bioimmunohistochemistry. So as I mentioned in the study design, the key eligibility criteria include unresectable metastatic adenocarcinoma of the colon or rectum. Patients have failed or progressed on 5-FU, oxaliplatin, irinotecan, an anti-VEGF monoclonal antibody, and an anti-EGFR if they're RAS wild type. There's no prior treatment allowed for TAS-102. However, the patients could have received prior regorafenib or fruquintinib. So as part of Project Optimus, there was a dose optimization step, that's stage 1, to randomize patients to 2 different dose levels of this therapy, IV Temab-A dose level 1 versus dose level 2. That stage 1 has been completed. Now we're moving on next year to stage 2, which will randomize patients to either, and this is a 1-to-1 randomization of 400 patients, to either Temab-A at that dose-optimized dose once every 3 weeks, or to the current standard of care in this population, which is TAS-102 plus bevacizumab. Once again, the key eligibility criteria is c-Met protein expression is more than 10%, staining with strong 3+ on the membrane of those tumor cells. So study endpoints are summarized here. In stage 1, the endpoint was response rate and safety. In stage 2, the key endpoints are response rate, dual endpoints of response rate and overall survival, with a key secondary endpoint of progression-free survival. Also, patient-reported outcomes will be assessed as well. There will also be other exploratory efficacy endpoints as well, geared more around patient-reported outcomes, time to deterioration of performance status, and other factors like global impression of severity and impression of change as well. So in summary, this is an exciting therapy. This is one that we think has already shown preliminary signals of activity, and we're now testing it head-to-head against current standard of care to see if it can displace that standard of care and meet an unmet need for our patients with colorectal cancer.